Good evening, everyone. I'm Dan Faulkner, RCDSO Registrar and CEO, and with me tonight is RCDSO President Harinder Sandhu. Thank you for joining this RCDSO Connect session. We're excited about today's topic, and we'll jump right into things shortly. Before we get started, I would like to recognize the complexity and privilege of gathering online today by sharing a land acknowledgement. The RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis peoples from across Turtle Island. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for this land. We accept our responsibility to each other and this land we live and work on in a spirit of peace, friendship, and respect. We are committed to actively supporting the necessary work towards truth, reconciliation, and equity. We embrace the role we play in regulating dentists, in protecting the public interest, and in strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. With that, I will hand things over to Harinder to introduce our first presenter, Dr. Susan Sutherland. Harinder?
Thank you, Dan, and welcome everyone. This evening, I have the privilege of introducing Dr. Susan Sutherland. Dr. Sutherland is an associate professor, faculty of dentistry, University of Toronto, and past dentist-in-chief and current staff member in the Department of Dental and Maxillofacial Sciences at Stony Brook Health Sciences Centre in Toronto. She has made significant contributions to dental antimicrobial stewardship in Canada and internationally, working with FDI, the Canadian Dental Association, the Canadian National Antimicrobial Resistance One Health Network, Choosing Wisely Canada, and the School of Pharmacy at the University of Waterloo. She is a co-investigator in several research grants to study and promote dental antimicrobial stewardship in Canada. With that, I will turn things over to Dr. Sutherland. Susan?
Thank you very much, Harinder. It's a real pleasure and it's a privilege to present here tonight. So thank you for inviting me. Next slide, please. So those attending will be able to claim 1 point in category 1 under the competency of dental public health. Next slide, please. I really don't have any disclosures to declare. Next slide. So the objectives are listed here. So I'm going to provide some background on antimicrobial resistance, dental prescribing of antibiotics, and I'm also going to discuss the issue of overuse in general and introduce you to Choosing Wisely Canada, an organization some of you may be aware of and others may not. And finally, I'm going to tell you about an exciting new toolkit to help dentists, physicians, and other providers reduce unnecessary antibiotics for patients presenting with toothache. Next slide, please. So you asked questions when you registered. You had the opportunity to put forward some questions. So here's a couple. What do we mean by antimicrobial resistance? And how do you know that your patient has developed resistance? Next slide, please. So microorganisms or bacteria become resistant to the drugs used to treat infections. It's not the person who's resistant, but the bacteria that's causing the infection that's resistant. And in fact, resistant bacteria can spread from one person to another. You hear about MRSA breakouts in hospitals and nursing homes and so on, when one person has MRSA and then the whole floor gets it. So this occurs at both the individual level and the population level. And in the little picture on the right of the slide, we can see that antibiotics apply selective pressure on bacteria. So before selection at the top, there's only a couple of dark red bacteria, which are the ones that are highly resistant. And an antibiotic is given and the low resistance ones are killed off. And we end up with a population of highly resistant bacteria. Next slide, please. So Antimicrobial resistance continues to be a significant problem worldwide. Overuse of antibiotics contributes to resistance, and this is compounded by the problem that there are very few new antibiotics coming to market. There are nearly 5 million deaths annually from AMR, according to the World Health Organization, and data published by the Council of Canadian Academies in 2019 shows that this is really an escalating problem in Canada. 26% of infections currently are resistant to first-line antimicrobials, and it's estimated that there are 6 deaths per day in Ontario related to AMR. Modeling of the data from this report indicates that by 2050, resistance rates are likely to rise to 40%, resulting in 396 deaths and GDP decline of $388 billion. Next slide, please. So let's talk a little bit about the concept of overuse. What does that term actually mean? Overuse occurs when the potential for harm is greater than the potential for benefit. This can include unnecessary, inappropriate, or low-value tests or treatments. Next slide, please. So examples of low-value care in medicine include things like pre-op blood work and ECG in healthy patients who are going to be undergoing low-risk procedures. That just isn't done anymore. Examples in dentistry include 3-month recalls in healthy patients with excellent oral hygiene, low caries risk, and no periodontal disease. Examples of harm include indiscriminate use of opioids or prescribing antibiotics when they really aren't indicated. Next slide, please. So I mentioned a few minutes ago that one of the threats to being able to effectively treat infections in addition to AMR is the lack of new antibiotic drugs. So this slide illustrates that as superbugs such as MRSA or VRE have increased greatly in the past few decades and are no longer susceptible to antibiotics, pharmaceutical research in this area has declined dramatically in the period from 1990 to 2010. Next slide, please. In fact, from 1942 to 1962, excuse me, while there were 20 new classes of antibiotics discovered, there have only been 2 new classes discovered since then. So why is the pipeline drying up? Well, there are very high development costs associated with developing new drugs. It's estimated to be about $900 million per drug. There are regulatory bottlenecks related to strict trial design and rigorous safety requirements. There's lack of investment in research in this area because of the economic realities. There's really poor financial return, especially when a new antibiotic is developed, and bacterial resistance can develop within a matter of years. Next slide, please. So let's talk a little bit about dental use of antibiotics. We know that 90% of antibiotics used in healthcare are prescribed in the community, and that 10% of those are prescribed by dentists. And this is a worldwide phenomenon. It hovers around 10%. Research has shown that up to 80% of antibiotics prescribed for dental patients are unnecessary. We use antibiotics for too long, and there's been a real increase in the use of clindamycin. This table, which I'm going to talk about in a minute from a study, shows that from 1996 to 2013, all antibiotics increased in use by dentists, but clindamycin increased by 789%, which is really quite alarming. And this is really related to heavy marketing that took place in the late 90s, early 2000s of clindamycin to dentists. Next slide, please. So data about dental antibiotic use in Canada is sparse. We don't have a lot of data from various provinces, but this study published in 2016 by David Patrick and his colleagues highlights the overuse of antibiotics by dentists and might reflect patterns in other provinces. So in the period from 1996 to 2013, the good news is that overall, 25% fewer antibiotic prescriptions were written, and this was attributed to major stewardship efforts directed at physicians during that period. So I think this 25% is probably among physicians. At the same time, dentists prescribed 62% more antibiotics, which is really quite astonishing. After that study was published, the BC Centre for Disease Control and the BC Dental Association partnered to mount a campaign aimed at dentists. And we don't actually have data that would indicate there has been a change, but it's hopeful that, you know, the campaign that was put on changed practice in BC. Next slide, please. So we all know that we prescribe antibiotics, and, you know, they're certainly needed in dentistry. There's no doubt about that. Excuse me. And we prescribe them for a variety of reasons, but there are three main areas that antibiotics are used in dentistry. Next, please. So we use antibiotic prophylaxis for the prevention of distant site infections. Next slide, or keep going. So in terms of antibiotic prophylaxis, I think most Canadian dentists use the American Heart Association guideline. And as we know, this really applies only to the very highest risk patients, those with previous endocarditis or prosthetic valves. And there's a few other conditions, but really quite limited. The other reason we used to give antibiotic prophylaxis was for patients with total joint replacements, and this is no longer indicated or advised. So in 2016, a consensus statement was prepared and issued by the Canadian Orthopedics Association, the Canadian Dental Association, and AMI Canada, which is the Association for Infectious Disease Physicians and Medical Microbiologists. And that statement says that antibiotics should not be given for patients with total joint replacements. And, you know, I'm pretty confident that dentists are aware of this and follow this advice. And just anecdotally speaking to orthopedic surgeons that I know, you know, I think there has been good uptake in the orthopedic community, although I'm sure there's still work to be done. The next reason we prescribe antibiotics is prevention of surgical site infections. And, you know, really the indications for this are quite limited. I'm not going to get into this tonight, but, you know, things like complicated implants with bone grafting and sinus lifts, or some impacted mandibular wisdom teeth, and of course, major oral surgical procedures to the maxillofacial complex have indications for antibiotic prophylaxis. And then the third area, and this is what we're really going to talk about tonight, is as an adjunct to definitive treatment for odontogenic infections. And, you know, of course, we know that dental infections are bacterial, and really the way to treat them is with source control, a surgical procedure, which, you know, endo extraction, and if there's an abscess, incision and drainage. But we do know from the literature that almost a quarter of dentists prescribe antibiotics for toothache, which is not indicated, and nearly half prescribe them for acute apical abscesses, also not indicated. Next slide, please. So I'm going to change direction a little bit here and talk to you about an organization called Choosing Wisely Canada, because Choosing Wisely is a major partner in our work in antimicrobial stewardship. It's a campaign to help clinicians and patients engage in conversations about unnecessary tests and treatments and make smart and effective choices to ensure high-quality care. Next slide, please. So we're going to do a little Slido poll. I think those of you who attend RCDSO Connect are familiar. You can join either by taking a picture of this QR code with your camera, or going to slido.com and entering the code 36660833. So I'll give you a minute to do that, and then you'll see the questions on the poll. So, okay, here are the questions. And we want to find out how familiar the people in this audience are with Choosing Wisely Canada. Okay. Go a bit longer and more people are probably still responding. Okay, I think we're falling in the range of most people haven't heard about Choosing Wisely Canada. So I'm really glad that I can tell you about it tonight. We'll go to the next slide, please. So Choosing Wisely was launched in 2014 by a team of Canadian physicians based at the University of Toronto and St. Michael's Hospital. It's a partnership with the Canadian Medical Association and a number of other groups that are supportive of its work, including many universities and hospitals and so on. What Choosing Wisely encourages conversations between clinicians and patients about care and encourages these questions to be asked. Do I, as a patient, or does my patient really need this test, treatment, or procedure? What are the downsides or risks of having this done? Are there safer, simpler treatments? And what happens if we do nothing? And, I think probably as patients, many of these questions go through our minds. As practitioners, I'm not sure if we do that on a regular basis. So this slide is to indicate that Choosing Wisely works in a number of ways on a number of fronts. It's active in all 13 provinces and territories. It's active in 17 medical schools across the country where STARS are students and trainees and residents that are involved with Choosing Wisely. It consists of 84 professional societies or medical specialties or healthcare specialties whose groups are involved to advise Choosing Wisely. And the work of these societies is centered around developing lists of recommendations. So if we can just go to the next slide, please. So on the left-hand side of this slide is societies that have recommendations. And I know you can't read this, it's very small, but every medical specialty that you can think of, oncology, otolaryngology, emergency medicine, family practice, and so on, plus a number of other professions, including dentistry, nursing, nurse practitioners, pharmacy, and so on, are societies who are involved. And if you're on the website, if you click on one of these societies, it will bring up that society's list. And on the right-hand side of the slide, we have the hospital dentistry list. And I'm going to talk about that a little bit more. We can maybe just go to the next slide. And I'm pleased to say that this list is no longer called the hospital dentistry list. It's now just called the dentistry list. So the list was developed by the Canadian Association of Hospital Dentists in 2018 because we were the only dental group that sort of partnered with Choosing Wisely. I'm really happy to say that the Canadian Dental Association has become a partner and has taken over this list, and it is now, sort of maintained by the Canadian Dental Association and the Canadian Association of Hospital Dentists. We now have the opportunity to develop a list that's more specific to hospital practice. This list is not specific to hospital practice. It really applies to, all dental practitioners. So there are 8 recommendations in this list. On this slide, I have the first 4 things around antibiotics, around dental x-rays. I have a box around don't prescribe antibiotics for toothache or localized dental abscess, because that's going to be the focus of what we discuss around the toolkit tonight. And next slide, please. The other 4 relate to things like don't replace fillings just because they're old, or don't delay or postpone treatment, when there's public health directives, and that was developed during the pandemic. One around virtual care, and again, another one about antibiotics and opioids, don't prescribe them without examining the patient. Next slide, please. So I've just pulled out one. Don't prescribe don't prescribe radiographs without indication. And this one, so the recommendation is at the top. When you click on it on the website, it brings down the rationale and some resources. So we start this one off by saying that dental x-rays are important because these lists of recommendations are for patients as well as practitioners. So we want to, stress to patients that you do need to have x-rays when you need them, but then it goes on to say that, it should be on an individual basis and so on. And the resources for this particular recommendation are kind of generic. For most of them, we have sort of, the most current evidence from a systematic review or meta-analysis. Next slide, please. So there are a number of projects that are done by different groups that are involved with choosing wisely. One area where choosing wisely has had a big impact is generally in hospital practice. QI projects that are clinician-led, by usually groups of physicians in a hospital, for instance, supported by Choosing Wisely and by the healthcare organization, utilize innovative and evidence-based implementation science to develop toolkits or guidance around particular areas of overuse. So for example, and I know this one was developed at Sunnybrook where I work, why give two when one will do? And we know there's a big area of overuse in the area of blood transfusions. And so this was developed to encourage practitioners not to abuse giving blood transfusions. A couple of the other ones, lose the tube, urinary tract infections related to catheters. That's a big problem in hospitals. So this group developed a toolkit about, how to reduce using catheters in hospitalized patients. Next slide, please. And these have really been shown to be effective. For instance, the Lose the Tube toolkit has reduced inappropriate catheterization of hospitalized patients by 50% across Canada. So you can imagine the impact that has on patient outcomes, on hospital stays, and that kind of thing. And other ones, I've just put up a couple of the results of evaluation studies that have been done for some of the other toolkits. Next slide, please. So another Slido poll. What areas of dental practice do you think would benefit from Choosing Wisely recommendations? For example, areas where you think there might be overuse of diagnostic tests or overtreatment or a disconnect between patient expectations and the scientific evidence. So again, this gives me a chance to have a drink of water, and please just freely put up areas where you think there could be areas of overuse that perhaps, a dental specialty other than, the ones that are involved so far might develop lists and address some of these things. Wow, I'm seeing a lot around x-rays, PANS, CBCT. If there's any radiologists in the audience, maybe your society wants to join Choosing Wisely and address some of these things. Whizzies, I like that one. I have to say, these lists are not meant to antagonize anybody. So when we did our list, we avoided things that we felt were controversial. We want to encourage people to practice appropriately. We want to reduce overtreatment. We didn't want to develop anything, especially the first time out, the first list. We didn't want to get too controversial and have dentists say, oh, you're going to be affecting my bottom line kind of thing. But honestly, the things we're seeing here, I think I did this presentation and asked this question last week, and these things are coming up over and over and over again. Okay, so I think, we've got quite a fulsome response, and this is actually going to be captured by the RCDSO staff, and I can have a look at it later. So thank you very much. Okay, so there have been isolated dental stewardship programs in some provinces. I'm aware of BC and Saskatchewan, for example, but there really hasn't been a coordinated, structured Canadian strategy or action plan in terms of reducing antibiotic overuse. So my colleagues and I at U of T sensed a building interest in a consensus-driven approach to dental AMS and wanted to harness the momentum. Along with partners in the UK and Australia, we were able to get a grant from the Manchester, Melbourne, Toronto Research Fund to engage stakeholders in the development of a sustainable Canadian dental antimicrobial stewardship strategy. Next slide, please. Excuse me. So we planned a two-phase approach. We started with a focus group study in the summer of 2023 that informed the second phase, which was a workshop that we held in Toronto the following October. Next slide, please. So we held 4 one-hour focus groups on Zoom with a total of 22 participants. And those participants included dentists, dental leaders, physicians, pharmacists, dental educators, dental regulators, policymakers, and other advocates for stewardship. What we learned wasn't very different from what we already knew from the medical literature and the dental literature, but we heard it from the people we wanted to engage. We heard it from practicing dentists, from educators, and so on, people who wanted to be champions for stewardship. So a variety of reasons for overuse were put forward, and the need for behavior change underpinning any action plans was emphasized. Next slide, please. So 3 distinct themes related to overuse of antibiotics emerged. The first theme was old patterns. I've always done it this way. This was the way I was taught in dental school. Old habits are hard to break. Patient expects it. There aren't any guidelines. And, this has really been emphasized in the literature as well. And as one of my colleagues says, I don't get up in the morning and go to the office and decide that I'm going to overprescribe antibiotics, but there are so many factors, there are so many pressures, and old patterns is one of them. One dentist who was an older gentleman told us that in his office he had pre-printed prescription pads, one for amoxicillin, one for Percocet, because that's what a lot of patients just got routinely. Next slide, please. I presented with a physician last week at a Choosing Wisely Canada webinar, and she allowed me to use this slide that she put up. And this is from a physician's perspective, and it's, I don't know what to do. I can't, and what they hear from dentists or from patients is, I can't afford the dentist. I don't have a dentist. The dentist won't see me unless I take an antibiotic first. Or I can save the cost of a dental visit for a consultation by taking an antibiotic. Next slide, please. A second theme that we heard frequently was antibiotics are used as a Band-Aid solution. We heard comments like, you really feel like you have to do something. There's a lot of pressure. We have to get the patient through the weekend until Monday. We have to get them through until the oral surgeon can see them or the endodontist can see them. The patient might not come back, and I'm afraid that this is just going to blow up. They might not come back for a variety of reasons. We heard from family doctors. One said, we just don't know what to do with these dental problems. So, we put them on antibiotics. Another physician who said, I work in long-term care, and, there's never going to be a dentist come here to see the patient. Next slide, please. So fear and risk aversion is the third theme that we heard, and these things are really significant drivers. Participants told us about the anxiety they feel related to balancing the risk of a complication if no antibiotics are given against the risk of an adverse outcome from an antibiotic. And I think what one participant said that, it really resonated, and, this is quite true. If I don't give an antibiotic and there's a complication, well, the patient blames me. If I give an antibiotic and they get C. diff, well, that's the antibiotic's fault. We also heard from participants, there is a real fear of regulatory or legal consequences of not giving an antibiotic. And this is a big driver in medicine as well. Next slide, please. So in phase 2, in October of 2023, our colleagues from the UK, from the University of Manchester, and from Australia, the University of Melbourne, came to Toronto and joined us, the research team from U of T, to put on a workshop. There were 30 participants, and they were similar makeup, not the same people necessarily, but similar makeup of the participants in the focus group. So representing physicians, dentists, pharmacists, educators, and so on. We can go to the next slide, please. So at the end of the day, we wanted to come up with an action plan, and that was the work of the workshop. But we also heard the challenges and opportunities that people see in sort of pushing antimicrobial stewardship programs in dentistry. Next slide, please. So one of the big challenges is the absence of robust data. Other challenges were the things we just heard about, sort of the drivers of overuse of antibiotics and how to address those things. A lack of clear guidelines and lack of up-to-date teaching. The big thing that came out here was that we really don't have good resources. We don't have chair-side tools. We don't have toolkits and so on. On the opportunities side, next slide, please. One of the big things that came out was, there's a lot of opportunity in education, dental curriculum, continuing education. And I am happy to tell you that my colleagues from U of T joined with some colleagues at McGill, and we just got a CIHR grant to study dental education and to develop sort of standardized curriculum in antibiotic stewardship. But the big thing that we heard also, in addition to the lack of resources, was there's been a lot of great work done in medicine and pharmacy in Canada. There's been great work done in dentistry and the UK, so don't reinvent the wheel. Like, let's look at the work that's been done by other people. Next slide, please. So taking what we heard from our stakeholders, toothache is a big problem in terms of antibiotic overuse for dentists, for physicians, in practice, in emergency departments. We heard there's a lack of resources. We heard don't reinvent the wheel. And at the same time, we have a choosing wisely recommendation that says don't prescribe antibiotics for toothache or localized dental abscess. Next slide, please. So what we did was we partnered with Choosing Wisely Canada to create a toolkit called Taking the Bite Out of Tooth Pain. Next slide, please. We based the toolkit on a Choosing Wisely toolkit that exists for the common cold. It's called the cold standard. So we used a lot of the sort of proven methods that they use to address that problem with patients. The toolkit is intended for dentists, physicians, and other healthcare professionals managing tooth pain in adults. And when we first started, we thought we were going to just be doing this for dentists, but we had some physicians join the group, and they really, really were interested and really felt that they needed something that they could use in their offices. Next slide, please. Excuse me. So you asked a few questions. You asked, How do we balance the risks of overprescribing with the risks of underprescribing? How do I know which antibiotics to use? And just using pain medication doesn't take the pain away. Don't we need to prescribe antibiotics also to manage periapical inflammation? Next slide, please. So I think the toolkit answers a number of these questions. The toolkit was launched last week. It's on the Choosing Wisely Canada website. It is on the Canadian Dental Association website. And I've just selected a few pages from the toolkit to kind of show you the composition. But I really urge you to go and look at it yourself and scroll through it. It's set up, it's a digital resource. So as you scroll through it on the website, every aspect of it is downloadable. You can print it, you can print copies for the chair side, and so on. So this page is the standardized approach to managing tooth pain in dental settings. So this is for dentists, this part of the toolkit. On the first column under symptoms, you determine, does the patient have pain or do they have pain and swelling? If they have pain, is the tooth vital or non-vital? If it's vital, then you investigate further and, treat the cause. Is it, tooth pain in vital teeth could be, hyperocclusion, or it could be caries or whatever. If the tooth is non-vital, then of course endo or extraction would be indicated, and then so on down the list. And then pain and swelling, you decide, is there a localized abscess that can be incised and drained, or are there signs of systemic involvement, fever, trismus, malaise, or spreading facial infection beyond that, very localized abscess? So then under recommendations, the only indication for antibiotics is in the pain and systemic swelling category. And then on the far right are sort of tools. I'm going to talk more about some of these tools in particular as we go through. Next slide, please. So in non-dental settings, this would be, in a doctor's office, in the emergency department, it's a much more simplified standard approach. And, pain with localized swelling or pain with localized swelling and systemic involvement. And again, physicians would only prescribe antibiotics if there was systemic involvement. And the recommendations in both categories are follow-up with a dentist for a definitive diagnosis and management. And again, tools, which I'll go through. Next slide, please. This page is the antibiotic treatment page. So, in previous pages of the toolkit, in the right column, you could click on antibiotic treatment and it would bring up this page. So the first area is for patients who aren't allergic to penicillin, and the recommendation is amoxicillin, or if you prefer, penicillin. And then it goes through different scenarios, a patient with a non-severe allergy. And this requires, asking the patient some questions, describe your symptoms. Most patients can't remember. They say, I was 2 years old. And, so on. So it goes down to very severe and what antibiotics you would use instead of amoxicillin. If we could go to the next page, please. So you ask questions, how can we avoid overprescribing when patients insist that they need them? Big problem for everybody. And how can we get the word out to our patients? Next slide, please. So one of the tools that we think will be very helpful is what we call a toothache prescription or a dental prescription for pain management. In our focus groups, one of the physicians said, patients don't necessarily want a prescription for antibiotics. They want a solution. They want you to do something. They want help. So in medicine, there is something called the viral prescription, and it looks very much like this. We modeled it on that prescription. And this is given to patients who come in with the common cold, or there's one that's a viral prescription that's given to parents with children with earache. And, you know, it starts off, if we can go to the next slide, the top half of the prescription says antibiotics aren't needed to treat the symptoms you have today, and the little blurb about antibiotics. And then, you know, it says the symptoms you present with today suggest, and you can tick, you know, one or more of these boxes. Physicians would probably just tick the first one, you know, tooth pain. I don't know why, you know, the cause not yet known because you need to see a dentist. For dentists, it might be toothache. It might be, you know, maybe it's a patient with a dry socket who's come in and saying they have pain. Or, you know, it could be post-op pain or whatever. And next slide, please. So then this section is, you know, how can you feel better and treat your symptoms? And you can tick ibuprofen, excuse me. Or acetaminophen, especially if ibuprofen is contraindicated. Or, you know, for patients with severe pain, you may tick both and tell them to alternate or double up. You know, other things that will help symptoms, saltwater rinses, ice or heat, or other treatments. I'm not quite sure what those would be, perhaps, I don't know. It gives practitioners the option to recommend something else that they think would be useful for that patient. Next slide, please. So the bottom part of the tool is next steps. And, you know, the first tick box is really for physicians. You know, please contact your dentist and, you know, see them for definitive dental treatment. And then for everybody, please return to your, you know, dentist or whomever if you have these particular things, you know, fever, increasing pain, and so on, so that patients know what to do if they're not getting better. Sorry about that. Too much talking. Next slide, please. Another resource that we have is a poster, which can be printed, downloaded and printed, or used as a screensaver in offices, in waiting rooms, in treatment rooms. And the poster says, sorry, but no antibiotics won't cure most toothaches. And there's another little blurb below it that I can't really read right now, but you know, this is a conversation starter. And, you know, if this is posted in the waiting room, the patient may say to the receptionist, "Hey, what's this all about?" And that kind of speaks to the fact that all members of the dental team are really important if we're going to make any inroads in antibiotic stewardship in dentistry. Your assistant has to be able to say, yeah, you know, he's probably, you know, I've heard my assistant say, you know what, Dr. Sutherland's going to give you an antibiotic. And then I have to go in and say, well, no, I'm not. You know, so it's really important that these conversations, you know, can take place between all members of the dental team. Next slide, please. We've also developed frequently asked questions, and this one in particular is for patients. And this was developed with input from patient advisors from Choosing Wisely Canada. And these are questions that both we and physicians often hear questions from patients. Well, you know, why don't I need antibiotics? You know, I have, you know, a pacemaker, or I've had a joint replacement. So this is something that can be printed off and given to patients, you know, or they can access it on the website to answer some of the questions they have. Next slide, please. Okay, here's some more questions. So you asked, are prophylactic antibiotics still needed for patients who have a hip or knee replacement? And what about patients on chemotherapy and radiotherapy? Next slide, please. So those kinds of questions are answered in the FAQ for dentists and physicians. And this is a much more extensive list. Just excuse me. This, I think, is like 3 pages long. And the questions that we address in this FAQ are things like duration. Like, why are you only recommending 5 days of antibiotics? I was taught 7 to 10 days or 2 weeks or whatever. What do I do if first-line treatment fails? So that speaks to things, like, first of all, reevaluate. Is your source control appropriate? Did you get all the canals, or, do you need to bring the patient back in and, do an incision and drainage? And it also, in that answer to that question, talks about different antibiotics that you could introduce if your first-line treatment of amoxicillin fails. A lot of information around the management of immunocompromised patients, because that's something that comes up all the time. And there's some very good resources that have been published around immunocompromised patients that we talk about in the toolkit. There's frequently, an FAQ on antibiotic prophylaxis, and that's quite extensive. We go into the different regimens and so on. Questions about patients with penicillin allergies, and a question that we felt was really important is, why is clindamycin not recommended? So the answer in the FAQ explains that. Next slide, please. So a really big shout out to all those involved in the development of this toolkit. A number of dentists, a number of physicians, infectious disease physician, emergency physician, family practitioner. The toolkit was peer reviewed, and we are grateful to our 2 dentists and physician that reviewed it, and to the staff of Choosing Wisely Canada, who took all our ideas and put it into an easy to use and visually appealing toolkit. Next slide, please. Oh, this is interesting. I'm early in my career and working as an associate. What should I do when a more experienced dentist tells me I should prescribe antibiotics even when I know they won't help my patient? So we're calling upon you, the members of the audience, and to give some advice. Just type in, some of your ideas. These are great. Put your name on it if you're so confident. These are great. Yeah, a lot of provide references, so show them the evidence. Honest dialogue. Refer them to Choosing Wisely Canada. That's great. Oh, these are really interesting. Just don't. I like that one. You can give anybody my email. I'm open to that. Yeah, be kind, understanding. Yeah, I think that's really, really important. And that's something that I really want to stress, is that this, antimicrobial stewardship, it's really, everything we do in it is intended to improve the quality of the care that you provide. These aren't, regulatory matters. They're not, you must do this, you can't do that. We really want to provide resources that are evidence-based, that are sort of multifaceted, that are supported by leaders in dentistry, and that will help dentists practice appropriately. You're with the wrong dentist. Very good. Oh, this is excellent. Thank you. Don't be bullied. Sometimes easier said than done, isn't it? Okay, well, that's great. If we can just maybe go to the next slide now. So in summary, antimicrobial resistance does continue to be a global health threat, driven by overuse of antimicrobial drugs. Up to 80% of antibiotics prescribed by dentists are deemed to be unnecessary, and we aim to change that. Drivers of overuse include external pressures, prescriber factors, and patient characteristics and expectations. And well-designed toolkits and resources can help clinicians and patients reduce overuse. And as I said a minute ago, this is about quality improvement, supportive guidance, engagement, and commitment by our dental leaders. Next slide, please. So that's the end of my presentation. Thank you so much for your attention and your great responses to the polls. And I'm going to turn it back to Susan Taylor.
There we go. Thanks, Susan. So thank you so much for walking us through some of the history, not only to antimicrobial prescribing and what has unfolded over the last 20, 30, 40 years, but also the work that you've done in your research and how that led us to our collaboration with Choosing Wisely Canada. We do have a few minutes. I think we can take one or two questions. There was a question that came in through the chat, and it was asking about that patient who comes to you and they have multiple comorbidities. Do they need to have antibiotics prescribed before they undergo a procedure?
That is a really great question. And I think, in dentistry, and I've spent my whole career working with medically complex patients in a hospital. I think we confuse medical complexity with immunocompromised. And immunocompromised means that a patient cannot mount an immune response or can't mount a sufficient immunoresponse. And a patient can have multiple comorbidities, cardiac disease, diabetes, you name it. That does not make them immunocompromised. What makes somebody immunocompromised, relates really to their immune system. So a patient, for instance, on chemotherapy who has their neutrophils knocked out, who simply can't mount a response to infection. A patient with full-blown AIDS. In our toolkit, under that question, the answer is quite extensive. There's been a lot of work done in that area. There are definitions of, immunocompromised and so on. So I urge you to take a look at that. The one that always comes up is diabetes. Diabetics are not necessarily immune compromised. They may have wound healing problems, and wound healing problems are not, generally treated with antibiotics. We know that from dry socket, that antibiotics won't, hasten, the healing of a dry socket because it's a wound healing problem. So thank you very much for that question.
That's great. Thank you, Susan. And just one other question quickly, if you could you speak again just to the duration of the prescription? Because there seems to be a little bit of confusion about how long antibiotics should be prescribed for. Is it 5 days? Is it 3 days? Is it 7 days? Is there something there that you can clarify for us?
So what we are advising, and this is based on, pretty solid evidence, is 5 days. To reevaluate a patient, a quick phone call from your office after 48 hours to see how they're doing is a great idea. We have to remember that antibiotic duration courses like, 7 days, 10 days, 14 days, those were arbitrary. There was no clinical evidence, no research ever done to determine those lengths of time. Time was based on, culture and sensitivity in a petri dish. And, patients are different. We have other mechanisms to, help fight infection. So most of the research that's been done has been done in medicine for quite a number of conditions, respiratory infections, skin infections, urinary tract infections. And in a lot of cases in medicine, the ideal duration is 3 days. But I think people generally tend to say, 3 to 5 days kind of thing. In dentistry, there is evolving evidence around this. There have been some research studies that support the adequacy of 3 days of antibiotics. But until the literature, until the research is a little more evolved in that area, we're recommending 5 days.
Okay, that's great. Thank you so much, Susan. And if we could go to the next slide, please. So where to from here? So one of the things, and just quickly to conclude this section, tonight's call, we of course have category 1 points, but there's also an opportunity for you to implement the elements of the toolkit into your practice. And when you do that, you're eligible to earn up to 5 points in category 2, 1 for each of the areas of the toolkit that you implement. We will share this information on our website and out with you after tonight's call, but there is a link where you would go to indicate which areas you've implemented, and that will generate your certificate for those category 2 points. Okay, so thank you again, Susan, and I'll turn it back now to Dan.
Thank you very much, Susan Sutherland and Susan Taylor. That was incredible. I learned so much, and I hope you did as well. Antibiotic resistance is a global problem, and it poses significant threats to health. Dentists and their teams have an essential role in tackling this issue, and we heard from Dr. Sutherland just the role of all members of the dental care team who can help to influence the behaviors within the practice and with patients. The college also has a critical role in supporting effective education. And I'm really excited that the college is broadening our recognition of continuing education. For example, this past year, we approved 2 new and important CE sponsors, Special Olympics Ontario and Rainbow Health Ontario. And this direction beyond traditional education sources acknowledges the important role for education in patient-centered care and cultural competency, not just the clinical or procedural aspects of care. And as you heard this evening, education at the chair side is as important as education in the classroom. Organizations like Choosing Wisely Canada, that you heard a lot about this evening, they provide accessible information based on evidence to foster practice changes with chairside tools, resources, and reminders in the midst of a busy practice. Choosing Wisely Canada also embraces patient education to support dentists in their pursuit of quality care. We heard some really brilliant solutions to engage the patient, like that educational prescription, plain language resources to really support those conversations that you have with your patients every single day. The college will work hard to promote continuing education that helps you obtain CE points, and perhaps more importantly, leads to practice changes. So stay tuned for more innovative solutions into 2025. As always, if you have any practice-related questions, do not hesitate to reach out to the staff and the college's practice advisory service by email at practiceadvisory@rcdso.org. And you can also follow the college on LinkedIn and Instagram to receive our latest news, updates, and resources. We'll be sending you an evaluation survey about this evening's session. It's pretty short. It helps us to understand how we can make future RCDSO Connect events more valuable for you. So please use the event code 20241126 when completing the survey to get your CE certificate for this evening's Category 1 session. You can expect to receive your certificates about early next week. Also, our latest college newsletter will arrive in your inbox in early December. I hope you'll take the opportunity to read it. And lastly, we would appreciate your feedback on 2 open consultations on draft standards of practice that were presented to our council in late September and distributed broadly to the profession and to other stakeholders, including the public. These 2 standards are consent to treatment and prevention of boundary violations and sexual abuse. You can scan the QR code to visit our website for more information. You can also email our policy team at consultations@rcdso.org. As always, gathering your input and feedback is an important step in our standards development process. Thank you again for joining us today. Enjoy the rest of your evening, and we look forward to hosting you at our Connect sessions in 2025. Thank you.